Uterine fibroids, also known as leiomyomas or myomas, are noncancerous growths of the uterus that often appear during childbearing years. These benign tumors can vary in size, ranging from small seedlings that are undetectable by the human eye to large masses that can distort the shape of the uterus. There are different types of fibroids classified based on their location within the uterus. Submucosal fibroids develop in the inner lining of the uterus. These fibroids can protrude into the uterine cavity or even prolapse through the cervix. Intramural fibroids or interstitial fibroids are the most common type and develop within myometrium, or within the muscular wall of the uterus. Pedunculated fibroids are growths attached to the uterus by a stalk, either inside or outside the uterine cavity. Subserosal fibroids or subperitoneal fibroids grow outside the uterus, projecting towards peritoneal cavity, often causing bulging or a swollen appearance. Parasitic fibroid or subserous pedunculated fibroid that acquires extrauterine blood supply, usually omental blood supply, and detaches from the uterus. Intraligamental fibroids arise laterally and grow into the broad ligament. Other fibroids include vulval myomas and cervical fibroids. The process of a fibroid forming and developing symptoms is a slow process. The manifestation of uterine fibroids can vary among individuals, and some may experience no symptoms at all. Symptoms are seen in 30 to 50%. The symptoms are rare before the age of 20 and they usually appear between the age of 35 to 45 years. Fibroids can cause an increase in the amount and duration of menstrual bleeding. They may lead to irregular menstrual cycles. Some women with fibroids experience pelvic cramping or pain, especially during menstruation. They can cause a feeling of fullness or pressure in the lower abdomen or pelvic area. Fibroids can cause pain or discomfort during sexual intercourse. Large fibroids pressing against the bladder can lead to a frequent need to urinate. In some cases, fibroids can obstruct the bladder, causing difficulty in fully emptying the bladder. Pressure on nerves in the back or pelvis due to large fibroids may result in backache or leg pains. In some instances, large fibroids can cause the lower abdomen to protrude, giving the appearance of abdominal enlargement. Fibroids pressing on the rectum can lead to constipation or difficulty with bowel movements. Fibroids can sometimes cause complications during pregnancy, such as an increased risk of cesarean section or breech birth. Up to 40% of women with multiple fibroids are reported to be infertile. This may be due to the fibroid interfering with implantation, distortion of uterine cavity, and occlusion of fallopian tubes, and interference with spermatozoa movement and ovulation. Fibroids are more commonly diagnosed in women during their reproductive years, typically between the ages of 30 and 40. They tend to decrease in size after menopause. Having a family history of fibroids increases the risk. If a woman's mother or sister has had fibroids, her chances of developing them are higher. Studies have shown that African American women are more likely to develop fibroids than women of other ethnic backgrounds. They also tend to develop fibroids at a younger age and may have more severe symptoms. Estrogen and progesterone, hormones that regulate the menstrual cycle, seem to play a role in the development of fibroids. Fibroids often grow during reproductive years when estrogen and progesterone levels are higher. Being overweight or obese is associated with an increased risk of developing fibroids. Fat cells produce estrogen, and higher levels of estrogen can contribute to the growth of fibroids. A diet high in red meat and low in fruits and vegetables has been associated with a higher risk of fibroids. Some studies suggest that certain nutrients, such as vitamin D, may have a protective effect. Starting menstruation at an early age may be a risk factor for fibroids. Women who have never been pregnant may be at a slightly higher risk of developing fibroids. Late age for menopause. Some studies suggest that the use of birth control pills or hormone replacement therapy may be associated with a higher risk of fibroids, although the evidence is not consistent. Infections or inflammation of the uterus may be associated with an increased risk of fibroids. Accurate diagnosis is crucial for effective management. Diagnosis methods include medical history. Your healthcare provider will begin by taking a detailed medical history, including information about your menstrual cycles, symptoms you may be experiencing, and any relevant family history. A pelvic examination is often performed to assess the size, shape, and consistency of the uterus. Your doctor can sometimes feel the presence of fibroids during this examination. Transvaginal or abdominal ultrasound is a common imaging test used to visualize the uterus and detect the presence, size, and location of fibroids. This imaging method is often effective in diagnosing fibroids. Magnetic resonance imaging may be recommended in cases where additional details are needed, such as when the ultrasound results are inconclusive or for better visualization of larger or deep-seated fibroids. Hysterosonography or sonohysterography involves injecting saline into the uterus to enhance the ultrasound images. It can help identify submucosal fibroids, which grow into the uterine cavity. X-ray to identify large soft tissue masses and calcification. In hysteroscopy, a thin, lighted telescope is inserted through the cervix into the uterus, allowing the doctor to directly visualize the inside of the uterus. This is particularly useful for detecting submucosal fibroids. Laparoscopy, that is a surgical procedure in which a small camera is inserted through a small incision in the abdominal wall. Laparoscopy may be used to examine the external surface of the uterus and surrounding organs. Laboratory tests are not the primary method for diagnosing fibroids, but they can be used to rule out other conditions or assess associated factors. A CBC may be done to check for anemia, which can result from heavy menstrual bleeding caused by fibroids. Thyroid function tests may be conducted to rule out thyroid disorders, as these can sometimes cause menstrual irregularities or symptoms similar to those of fibroids. A pregnancy test may be performed to rule out pregnancy as a cause of symptoms, especially if there is abdominal pain or changes in menstrual patterns. In some cases, coagulation studies, such as prothrombin time and activated partial thromboplastin time, may be ordered to assess bleeding tendencies. Liver function tests may be done if there are concerns about liver health or if there is a need to assess the impact of medication on liver function. Treatment may depend on the severity of symptoms, the size and location of the fibroids, and the patient's overall health. Emergency treatment is required in cases of torsion, infected fibroids, or obstruction. Anemia should be corrected prior to definitive treatment. Watchful waiting involves monitoring fibroids without treatment, especially if they are small and asymptomatic, and particularly women approaching menopause. Only symptomatic fibroids are treated. Hemotonics to correct anemia. Antifibrinolytics, like tranexamic acid and NSAIDs to minimize bleeding. Continuous exogenous progesterone like Provera. Gonadotropin-releasing hormone agonists may lead to shrinkage of fibroid by 50% in 3 months and reduce bleeding and prepare for surgery. Gonadotropin-releasing hormone antagonists. Selective progesterone receptor modulator like ulipristal acetate may cause a more prolonged shrinkage of the fibroids. Myomectomy is a surgical procedure to remove fibroids while preserving the uterus. This is especially for the symptomatic patient with desire to preserve fertility. Myomectomy should never be done in pregnancy unless there is torsion, even at cesarean section unless it is to improve access to the lower segment. Hysterectomy involves the removal of the uterus and is a definitive treatment for fibroids. It is typically considered when other treatments have failed or when the fibroids are large or causing severe symptoms. In some cases, the ovaries may also be removed. Uterine fibroid embolization is a minimally invasive procedure where small particles are injected into the blood vessels that supply the fibroids, cutting off their blood supply and causing them to shrink. Endometrial ablation destroys the lining of the uterus and can be effective in reducing heavy menstrual bleeding. It is not a treatment for fibroids themselves, but may be considered if bleeding is the primary symptom. MRI-guided focused ultrasound surgery is a non-invasive procedure that uses focused ultrasound waves to heat and destroy the fibroid tissue. It is an option for certain women who want to preserve their uterus and avoid surgery. Laparoscopic myoma coagulation with laser. While uterine fibroids are generally noncancerous, they can lead to complications. Depending on the size and location of fibroids, they may interfere with fertility. Fibroids can increase the risk of cesarean section or breech birth, preterm labor, premature rupture of membrane, and postpartum hemorrhage. Heavy menstrual bleeding caused by fibroids may lead to anemia. Large fibroids can press against the bladder, causing urinary problems. Chronic uterine inversion due to a prolapsing fibroid. Myomectomy has possibility of causing adhesions with risk of tubal occlusion and infertility. We hope this video has shed light on the causes, symptoms, and treatment options available for managing this common yet often misunderstood condition. If you have any questions or would like to share your experiences, please drop a comment below. Don't forget to subscribe and hit the notification bell to stay updated on our latest content. Until next time.